All right, I want to welcome back Abby, Migliore, the COO of Intervention Project for Nurses, and Shannon Opie, the CEO of Intervention Project for Nurses. Listeners, this is part two of our time with them. And on a previous episode, we spoke more in detail about IPN, some statistics surrounding those that admit substance use and substance use disorder by licensed nurses, neurocognitive testing, and medication-assisted treatment. Today, we're going to tackle THC. It continues to amaze me that facilities don't have solid diversion mitigation and monitoring programs in place. But what perplexes me even more is even those that do, they still seem to want to ignore or struggle with what to do about THC. They always ask, what should we be doing? They're usually not doing anything, so they know they should be doing something. But they choose not to test, probably because they don't want to know, or they're afraid they won't have any staff left if they start to test. So, ladies, what are your thoughts on why facilities aren't testing? Do you think it's because they don't want to know because they won't have any staff, or do you think it's something else? Shannon, let's start with you.
In speaking with some of our Florida larger hospital systems that have told us that they decided not to test, they've told us that some of the reasons are because people have medical marijuana cards and they don't want to get involved in any potential legality issues, or to be contested that the person doesn't, need or require the substance, even though it's not a medication that is regulated. If they qualify for a card, the facility has determined that they don't want to be involved. And so they have just chosen in those circumstances to not test, which we find concerning for sure.
Right. And Abby, before I hear your thoughts, getting a medical marijuana card, from my understanding, I think is fairly easy, right? I mean, it's not like that too is not regulated. Is that what you heard?
From our understanding, correct, yes. And there's more and more providers, becoming available, and then dispensaries obviously popping up all over the state.
Right. Okay. Abby, your thoughts?
So when we talk about cannabis and we talk about marijuana and THC, there's been a lot of changes from my perception, kind of very quickly, especially when we talk about substances or legalization or things like that. So, as of 2024, 24 U.S. states had legalized non-medical or recreational marijuana and medical cannabis use, with additional 14 states, really looking at permitting that medical marijuana. So that is a huge increase, especially when you talk about, rules, laws. Those are usually pretty slow boats, right? Since Colorado and Washington were the first to legalize a recreational use of marijuana in 2012. So you're talking about 12 years, an additional, 22 states, and more every day, it seems like. So for one, we are going fairly rapidly. So when things happen rapidly, I think especially when we're talking about in the legal sphere, which is what we're talking about with people's licensure, people's employment, you want to make sure you're doing the right thing, but also protecting the population you're serving, which is the patients, which is the public. So again, I think that's one thing, is sometimes the information there is rapidly changing, or at least that's to their recommendation or their thoughts. So as they look at these things, they have to look at, well, what's currently right now. But also there are a lot of organizations or people who look at the safety sensitive and things related to cannabis or mood altering substances in the workplace. So when we're talking about safety sensitive positions, we really want to talk about like that impairment issue. Also, one of the things is they do have several places do have some safety sensitive position statements related to marijuana, and they've done some studies now, depending on the years of the studies. But one of them with the National Safety Sensitive Commission did do studies that they did find that there were more industrial accidents, more injuries, and a greater absenteeism for work. So again, all these things need to be looked at when we're also talking about in the workplace or safety sensitive position, versus also the legality. So if an organization is just ostrich in the sand, just completely ignoring it, they might not also be keeping up on this kind of rapidly changing environment, both legally and what's being out there, which is, I think, very, very important right now, especially as this is a very fluid, very movable topic right now.
Right. Yeah. Yeah. You mentioned, so the National Safety Council says that there's no safe level of cannabis use for safety sensitive positions, right? And then you had sent me a study that I read out of Colorado, the front runner, right? That was published in JAMA Network Open that says cannabis reduces brain activity in certain areas of the brain involved in important cognitive functions, such as decision making, important for healthcare providers,
Yes.
workers, also memory, attention, and emotional processing. They found that 63% of heavy lifetime cannabis users exhibited reduced brain activity during working memory tasks, and 68% of recent users also demonstrated a similar impact. So, these are all the studies and the things that are coming out now that even if it's legal in your state and you have a medical marijuana card, it is causing a problem. I mean, is it kind of likened to, alcohol may be legal in your state as well, but you shouldn't come to work drunk. I think maybe
Exactly.
the difference is how long is cannabis in your system? And that's where things maybe aren't as cut and dried as they are alcohol. What are your thoughts on that?
I mean, I think that's hitting the nail on the head is kind of likening it to, just because it's legal, it's still impairing. It doesn't mean that it makes it okay for a healthcare practitioner or someone in a safety sensitive field, whether it's DOT, Department of Transportation, FAA, healthcare, or any other safety sensitive positions. They take a very strong stance. And right now, often are still using the fact that it's federally still not legal, even though states are making it both recreational and medically legal. Many states, as Abby pointed out, very rapidly. But that doesn't mean that just because it's legal, that it's okay for safety sensitive providers or practitioners to use these things and then go to work to be in practice, because alcohol is legal, and that's one of the highest abused substances that we see people needing intervention and treatment for, and to be pulled out of work for, and causing patient harm, if we're speaking about nurses or other healthcare practitioners. So yeah, the marijuana issue it's highly concerning. But I do think that because there is a reference to it as a treatment or a medication, when it's not a medication. You typically don't smoke medications, and we know now that it comes in many forms, but it's not regulated dose wise. You really don't know if someone's using it in a recreational sense, if someone's using excessive amounts of more than what's recommended by their prescriber, even though they're not really prescribing a medication. They're making a recommendation for marijuana, for cannabis. And so, there's just no regulation for what this person is potentially ingesting. And so we don't know the levels of impairment that the person can have. And then they're going to these really highly safety sensitive workplaces. So it's very concerning.
Right.
Yeah,
And
I
then
think
how to measure it.
yeah,
Right.
absolutely.
Yeah.
And then I think another thing is when we're talking about, since we're throwing out alcohol here, I think it's a pretty widely acknowledged fact that alcohol is legal and driving a car is legal, but you can't do those. As soon as you do those two things together, it's illegal, right? So I think we also look at the situation. I think, a lot of times we get in the weeds of, because there's a lot of perceptions about marijuana from all aspects, right? People are very passionate about this topic from all different things. But I think what we really look at from a safety sensitive position, and especially as IPN is a monitoring program, we really look at it not only is it a mood altering substance that can be misused or dependence, but also it is it is an impairing substance. Even if you look at some of these things that are promoting marijuana or the dispensaries, they talk about, a lot of them will even have their safety while impaired or safety while using kind of verbiage that while you're high or buzzed, don't do these risky activities that,
It's their
eating this much
disclaimer.
will come. Yeah.
Mhm.
Yeah. So, I mean, even they're acknowledging that it is an impairing substance.
Yeah.
So, they really talk about from, anywhere between 3 and 10 hours. It really depends on mode of usage, how, smoking, ingestion, kind of things like that. How much you take, when chronic use versus not. Marijuana is an interesting thing. It's so lipophilic, so it means it binds to fat cells so much that it even how much is in your body if you're your weight, your versus. So it's a really interesting compound and substance. And so when you're talking about that of how long or thing, it really depends on a lot of things with that. But pretty much everyone admits it is an impairing substance. So, again, when somebody is in a safety sensitive position and they're making higher calculations with medications to give or having to monitor from somebody for very finite changes, things that alter that higher brain function, that frontal lobe, the decision making can be very dangerous in those situations.
Yeah, I mean, do we have somebody surely must be studying it somewhere, but do we have any, yeah, you hit it all, chronic versus recreational. Can I still show metabolites if you test me, but I'm cognitively fine? Or as long as I have metabolites, I am not cognitively fine, even if I think I am? Do I just not partake within 48 hours of going to work? Or, I mean, I don't think at this point we have any, and that's the problem, right? We can't define, if I were to come in and be tested positive, but say, well, I haven't had anything in 5 days, test me cognitively. Could I pass the cognitive test and still have metabolites? And so I'm good to go. I mean, it gets very complicated.
And it would vary person to person. And again, we don't know how much you're using, how you're using it, like Abby was saying, your fat storage, how long it's going to stay in your system, how long it's going to stay positive. You could have a one-time use and stay positive for 30 days, or you could, and so we don't, there's not a way to really monitor it for safety. And who is going to take a risk and say, let's try this out in a safety sensitive position and see if this person can use this medical marijuana and then, take this test and then still just show metabolites and then go to work and see how they function, or can they do higher functioning things? And, so that it's just such a risk. It's a huge concern.
Yeah. And would it be safe to say that the occasional recreational user might actually be more dangerous at the bedside because they don't have tolerance and no reason to think they're affecting anyone because I'm just occasional, versus the chronic user maybe that has kind of a baseline? I don't know.
Interesting.
I think they're
No,
both
please go ahead.
dangerous. I was
Yeah.
just going to say,
No.
I think they're both dangerous. Again, I think it depends on the individual.
Yeah.
There's a lot of factors there, but go ahead, Abby.
No, I think you said it pretty, exactly. And I think again, I'll say the word interesting when it comes to this because I'm fascinated by these, compound substances, which is why one of the reasons I do this. So I kind of go down those rabbit holes of the research. But it's really interesting when we talk about mood altering substances or things, even prescribed, non-prescribed, illegal, illicit, they have this component of making pathways in the brain. They've actually been able to find that in MRIs and imaging and how the brain functions. So sometimes when people are utilizing these substances, they may not have that awareness because it actually is affecting that brain cognition, the brain, how the brain works, everything like that. That's why sometimes you'll talk to somebody who's maybe, well, let's stick with the thought of alcohol, and they're like, I'm fine, and they're walking into walls. So again, sometimes people who utilize some things may not understand the full impact of what it's having on their brain structure. Maybe they're fine, maybe they're not, but I'll tell you right now, if you make an error in the workplace and then they do a drug test and maybe you're 10-15 days out, and maybe you can have that argument, but it's the metabolites, the things may show up in your urine. Then how are you going to prove it wasn't an impairment issue?
Right. Yeah. So that's a little bit of a self-preservation issue, people. That,
Yes.
yeah, if they test after the fact, you may be sunk. Interesting. Okay. I wish I could, I would, and if anybody listening heard this and can tell me where we heard it, I heard a gentleman that was in tests for the effect of marijuana use, and he was taking in this in the morning, and then he would go to work in the afternoon. And from what I recall with what he shared, he thought he was just performing very well at work. I think this was like a summer internship or something. He was on top of his game. He was really doing great. The study ended before his job ended for the summer session. And so his cognitive performance, I guess, got a little bit better as time went on. But he ended up having a conversation with his boss at his job and found out that they were ready to fire him because his performance was so bad when he thought he was rocking it. And so related to his morning marijuana studies, and it was separated by like, I don't know, 4 hours or something before he went to work. But it was just interesting. What I got the most out of that was that his perception of his performance was so diametrically opposed to his coworkers and his boss's perception of how he was performing. And that just amazed me that you could be so different. Yeah.
Definitely. And that's why it's really scary too, to even think about just people using cannabis and driving. We know that it's highly impairing just using and driving, just like drinking and driving. People who drink and drive typically don't think that they're too impaired to drive. And it's the same thing with cannabis. And, there are a lot of accidents caused because of even medical marijuana use, cannabis use. Again, we don't know how much content of cannabis is in a lot of these formularies. And then people are driving, people are going to work, people are dealing with patients. And so their perception is that they're doing well. And that certainly may not be the case, as you just explained. So it's very scary.
Yeah. So recently, the DEA is making moves to reschedule products containing marijuana. The full DOJ title for the ruling is Rescheduling of Food and Drug Administration approved products containing marijuana and products containing marijuana subject to a qualifying state-issued license from Schedule 1 to Schedule 3. So let's kind of break this down. First, what products would this encompass? Because as far as I'm aware, there isn't an FDA approved product at this point to be rescheduled.
Well,
do you guys agree with? Do you know of one?
Well, yeah. So I am so happy you brought up this DOJ because it said final order, but though they're probably thinking it's going to be another final order in April 2026. So obviously we're pretty close to this. So they're really kind of finiting this thing. So you're right in the fact that from my understanding, the FDA does not have an approved cannabis plant for medical conditions. So they haven't done the actual plant, but now there is a ton of substances beyond, there's a bunch of substances in the marijuana plant or the cannabis plant, beyond just what kind of we think of. So there are 4 specific prescription medications that are derived from the plants from structures within. So you have like Epidiolex, Marinol, Syndrose, Casamet, things like that. So obviously Epidiolex is from the CBD, Marinol and Syndrose is like a synthetic, the THC synthetic, that's very generalized descriptions. But so there's the FDA doesn't have they haven't approved the medical plant, but they do have a few that are from some of the compounds in the plant. Again, I've got to pull up the actual study, but I think I've studied like hundreds of compounds with hundreds of things that are in these plants. So they're very complex. And yes, the new scheduling, the DOJ is kind of some really interesting factors in that of what they said, because they've really said that the FDA, these FDA medications and anything that the states have approved for medical marijuana, so the cards, those that are produced and provided from somebody with a medical card, can be scheduled, that Schedule 3, which is still a mood altering substance, but it says that there may be some medical usages versus a Schedule 1. But interestingly enough, the states that don't have the medical marijuana or the ones that have any recreational use are still considered a Schedule 1. So it's a very interesting.
So like if I had my card and I could go in, it would be a 3, but if I didn't have a card, it would be a 1.
Yeah, isn't that interesting?
Huh. Okay.
Yeah, and so they're kind of really teasing that out. At this point, they're really looking at that. But yeah, they're saying that like recreational. So even the states that have like medical and recreational, the recreational is considered, from what the descriptions of what the lawyers are saying at this point sounds like the recreational may still be that Category 1.
Same product.
And it's really kind of it's kind of delved down to the kind of that state level.
Interesting. It's kind of along the same lines. I mean, the schedule doesn't change, but if I have a prescription for oxycodone, then it's legal. If I don't have a prescription, it's not, but it's still a 2.
Right. So, right.
Exactly.
So, so that kind of that little distinctions are a little interesting with this, because even if you look at the Controlled Substance Act in Congress, kind of how they're describing it right now, because I've kind of been paying attention to this, because the thing they're talking about recreational marijuana and its derivatives remain classified as a Schedule 1 controlled substance, meaning their manufacture, possession, and distribution are considered illegal, except for the purpose of federally sanctioned research. So again, that research component, which has always been kind of one of the proponents for making it a 3, is to kind of take some of those, you can still do research, but it's taken away a few of those hurdles with doing the research, which everyone, I think, agrees that really we need more strong research on marijuana. And what I say, and the cannabinoids and just the processes, what I say by strong is it's really important, I believe, that we look at, peer reviewed IRBs, the really strong research, because with any medication, I'm going to say that because somebody's going to yell at me, because there's a financial back this, and there's really strong feelings about marijuana that we really need that strong research. So I think that is an argument for the classifications. But yes, this law, or this DOJ final ruling is really interesting on how it classifies it.
Interesting. So what I find is a lot of facilities, and this even pertains to not so much, although it could, if a facility wanted to enforce that their employees it has to be a cannabis-free workplace. And it certainly points to, we get asked from the pharmacy perspective, oh, the patient wants to take their own marijuana, or they brought it in, what do we do with it? We have always been able to fall back on, well, it's illegal federally and we're getting federal funds. So the end, right? The answer is no. With this in the wind, then facilities may have lost that soundbite that they've been able to fall back on. What are your thoughts on that?
Yeah, I mean, I think it's going to continue to be a very fluid situation. Unfortunately, we feel like we're in the same boat. I think within the next 5 years, the picture is not going to look the same as it does now. I mean, it's already shifting. The pendulum is swinging. In conversations with our own Department of Health, they have a very strict stance, which we also hold, that we're not allowing people in our abstinence-based monitoring programs to be on medical or recreational marijuana, obviously. Just like we don't allow them to consume alcohol or any potentially impairing substance unless something is, recommended medically by a doctor, and then they're refrain from practice for a period of time, depending on what it is. And so we hold that stance and use the same language. It's federally banned, it's illegal, and we're gonna hold on to that stance. But again, we know that this is a fluid situation, and we're looking at things like, are we gonna start? I remember years ago, one of our evaluators, who's no longer actually an evaluator for us, but a former evaluator, had a very early on medical marijuana person that had been referred to IPN because they tested positive for marijuana in the workplace. And the evaluator asked, can they just have neurocognitive testing? Kind of like what we talked about, is this something that we can just do and test and see, are they safe to practice? And we were like, absolutely not. We're not going to start allowing people to take marijuana, to use marijuana, something that we can't, regulate, know what their dosage is, know if they're impaired on any particular day more than another, driving, taking care of patients, things of that nature, and just took a strong stance. But, in the future, is that something that our Department of Health is going to allow? I don't know. I think it's, that is a huge concern, I think. I do think that pendulum is swinging because of the schedule changes and because of the federal changes. But we're going to still continue to ensure that we're prioritizing patient safety first, with whatever means we can. And we do regular cannabis testing on all of our participants,
Okay.
whether that's a drug of choice or not. And that's something that's part of an initial evaluation as well. So
What are you seeing? Are you seeing, I mean, everybody talks about it, but maybe not as many people are doing it and partaking. What are you finding when you do your testing in general?
we are actually seeing a lot of marijuana. So people are using it. And I would say the majority of them do not have cards. A lot of folks say that they're using things like gummies or like CBD products that happen to have THC in them. Again, these things are not regulated. So they're like, oh, I took CBD for sleep or something, for pain, and then tested positive. And again, we have no idea if that's true or not. But they still have THC in their system, and then they're going to work as a nurse, taking care of patients. So it's concerning. It's very interesting, but we do see many referrals based on a positive test for THC in the workplace.
Okay.
Well, and it is interesting that that they have actually still quantified marijuana as illegal on a federal level. It's just the Department of Justice has moved to restructure and reschedule those state level medical marijuana and those FDA ones as that scheduling. And again, the argument I've heard is for research purposes and other things, obviously that thing. And And like Dr. Opie said, one of the things is with medical marijuana, it's very fluid with these programs. You never, we always have to look everything with case by case. But, the thing about people in alternative discipline programs is they've been, to be in one of these programs, you have to admit that you have an illness or disease that could impair your practice. So they already maybe have those pathways. So that might something of mood altering, even other prescriptions. They're addictionologists, they're physicians. They look at. We don't say that they can't be on those mood altering, but they work with their physicians and they may find something that's less, impairing or worried about those pathways, to get them on. So again, with the same thing with medical marijuana, they may look at those and in treatment or things like that, look at ways to, treat whatever is going on with something that's maybe possibly less impairing so they can, things. So again, all this is very, very fluid when we're talking about this. But I think the big thing is, most nurse practice acts around the country, most things talk about that you cannot provide impaired practice, on legal, illegal, illicit, over the counter, you can't give impaired practice. I think that's really the core speaking point for somebody in like the healthcare or a safety sensitive position.
Okay. So I want to clarify something you said, Abby. Even with this new DOJ rule coming out or being evaluated, it's still not going to be legal federally.
Right. So right now they're still categorizing it on all the on the Congress and legal as still federally on a federal level. It is still that illegal. Now, is that going to change? Is that going to be modified? Like you said, this DOJ is very, very early on, but it really, the DOJ is really talking about those very specific things that it's recategorizing into that Schedule 3. And again, I think it's important also, this, look at what a Schedule 3 is. A Schedule 3 is still a medication that can be mood altering, can have a possibility of addictions or dependencies, that need to be very careful about the usage, and things like that. So it's just from a Schedule 1, which says it has absolutely no medical, right? No medical, usages or things like that. So again, as we're talking about, and that that they are saying maybe marijuana does or doesn't. I mean, that's the question, and that's why those schedules. It doesn't say it's not a mood altering or thing, or if used without prescriptions or whatever, wouldn't be illegal. It's just saying that there may be or may not be medical treatment purposes.
Okay, so from a legal perspective, if a nurse walked in or any healthcare professional in a state that allows medical marijuana and they have a medical card for chronic pain, anxiety, whatever it is they have it for, legally, they could still be told, no, you cannot practice here, even though you have a legal medical marijuana card in your state. We can still use the federally, it's illegal.
Right.
It obviously impairing. I mean, what we'd want to tell them is not a chance. It's impairing, right? But from a legal perspective, and I know you're not lawyers, but it would, I think still fall back on.
I think it depends on, the facility. I mean, I think that's facility preference. We still have the ability, like I said, as of now, as an abstinence-based program for impaired professionals, to say no, like that's just not a substance that we're allowing in now. But and thankfully we have a Department of Health that backs us on that very strongly. However, some facilities do allow their employees to, knowingly use medical marijuana, and they, aren't testing, as we talked about from the beginning. So yeah, I do think it's facility choice.
Yeah. Do you think they're actually allowing it, or are they just not asking?
No, I know there's some facilities that that are aware that they have staff that has medical marijuana cards,
Hmm.
and are still, because people do pre-employment drug screens and things of that
Sure,
nature.
sure.
And
Yeah.
so, if they tell them, hey, I have a card, then when it comes up
They test
positive, then
positive. Yeah.
they're not taking action, essentially.
Mm.
So, and I recall the first time I heard that was from Colorado, a facility in Colorado, and that was kind of their state stance.
Yeah.
If it was a pre-employment drug screen and they had you know, um,
Yeah.
a positive test with their stance on marijuana there, they just would not take action. So,
Yeah.
since
I guess
there was
that's,
no evidence of impairment at the time
yeah.
because it was a pre-employment. So,
Yeah, you're
Well,
right. I guess that's the logical progression to that, but I never made that conclusion. But you're right, because we all have to do the pre-employment drug screening, right? All
mhm.
facilities seem to have that at least locked down. Abby, you were going to say something?
yeah, I was going to say, Dr. Opie and I went to the FSPHP ANA as well, or AMA, the American Medical Association. This was a topic that they had discussed as well, and they really follow that the National Council on Safety Sensitive as well, that position. But I've had this conversation kind of a lot with people, and they're like, "Well, everyone's doing it. All these kids are doing it. All the da 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 da." And I said, "Well, the problem is." Again, back to my thing is if somebody has an error and then they go for a drug screen and at that point somebody tests positive, that could be an issue for the facility, for the
Mhm.
person, for things like that. And I tell them, I'm like, yeah, okay, so you're saying everyone's doing it and you're doing it with no problem. Well, till there's a problem.
Right.
Right.
You know what I mean? So from a perspective of an employer and the nurse themselves, beyond what you feel about marijuana, one way or the other, you
Mhm.
know, the right now with the federal, the even this reclassification, you're really talking about medical and the FDA. So if you don't have one of those or you're not in one of those states, the employers, the things, it's when I used to work at a board nursery with the regulations, it was, I'd hear this a lot. Oh, I did a workaround and everyone else is doing that workaround, but there was an issue with that one. I said, well, that's a problem. You used it and there was a
Right.
problem. Now you're in front, so I try to talk to people about, not only the legal, the federal, but kind of the operational, like let's walk this down that timeline too of if there is an issue or if there is something, how do you prove, again, back to there are points earlier, how do you prove where you were impaired or not? So all these things need to be looked at even beyond, I think, is it a Schedule 1? Is it a Schedule 3? Is it federally
Right.
legal? Is it things like that? Everyone kind of acknowledges it is a mood altering. It can, it is impairing, just like everyone admits alcohol can be impairing. It's again, how do you prove you're not impaired at that time?
Hmm.
Yeah.
Yeah.
Yeah. I think what we've said a couple times, at IPN is like people are missing the plot. Like we're missing the story here. And the issue is, do we, when it comes down to it, either from a liability standpoint, from a patient safety standpoint, do we really care if a person has a little piece of paper, a card that says that they can use it or not, or if something is legal or not, like alcohol, or
Right.
in terms of cannabis, whether they took it in a gummy form or they smoked it or they did, whatever, edibles or all those things. Either way, it's been proven time and time again to not only be becoming stronger in percentage and dosage and formulary over time, over these decades, but more impairing and dangerous, and obviously causing impairment in like every study that we've heard. And so for safety sensitive positions where the conversation has shifted so much to legality and the scheduling and all this, federal and state and all these things, but ultimately we're still talking about an impairing substance and the risk to the patients, and that's really what we need to, I think, continue to focus on.
Yeah, I think that's a great summary. You just answered my last question without
Oh.
realizing it. So I'll ask it, and then Abby, if you have anything that you want to add, because I think that was great. And that is, what would you say to the CNO listening right now who has a don't ask policy, but they know they have employees that are using it?
Well, and I'll add on to the, with IPN, with our purview, in everything, we always tell them to follow up with their medical provider when they're making medical decisions. And obviously that they, if they do have the diagnoses of some kind of substance, that they share that. A lot of times that's taken into account if they even do qualify for a medical card or something like that. So again, we do, we are not the medical providers. We understand that. So we do, let the medical providers, but obviously, we all follow our directions from our Department of Health, and that's, something, because they've made that stance, and we work under contract with the DOH. So those are all things that we look at, and I would kind of say the same thing to a CNO, is look at your policies, look at your procedures, look at, your facility policies and procedures. A lot of times they do have that drug-free environment policy,
Mhm.
things like that. They may have those policies. And obviously back to the liability issue, if somebody makes an error and you absolutely know they were, and then what happens if they say, well, I was impaired, I smoke? And back to our point earlier, it said, good grief, it's such a range. They talk about that you can compare you from 3 hours to 10 hours. Sure, if you said maybe you smoked 10, 20 days ago, okay, but like, somebody who smoked the night before, and then like, especially a chronic user, and then comes to work the next morning, could that still be in their system? Same thing like alcohol. If you had a really heavy binge the night before, could you still blow positive, and stuff? And so in each of these aspects, you kind of need to understand, again, personal feelings aside with marijuana, because everyone has, those arguments, is what is the risk to the public, because that's what we're here for, is to ensure public protection, make sure that we're safe to give care, and that that person is safe to give care. And again, that can go beyond the question of just the cannabis or marijuana, but it ultimately goes back, are they safe to give care?
Yeah, and should healthcare professionals be required to hold to a higher standard? I mean, that's just, we have patients' lives in our hands, and we're making
Exactly.
decisions, and we need to notice when, a nurse at the bedside needs to notice when there's a change in condition that warrants a, call to the physician or some sort of action before it is a full-blown emergency.
Exactly.
So, yeah, okay. Well, it could be a straightforward thing if you just say, nope, not at my facility, but then you might not have staff. So yeah, all right, definitely not a straightforward subject, but
No.
although it should be based on our discussion. All right, thank you both very much. Thank you, listeners, for listening, and this was a great conversation. I think people may have gone in circles with us and we didn't really tell them what to do, but hopefully we gave them some really solid things to think about and to consider, because it's important.
Mhm.
All right. Thank you,
Thank you.
ladies.
Thank you.